Hey guys, welcome to another episode of the Human AI Podcasts. Today we're talking about ischemic heart disease and interstitial lung disease. Nice combo for you all. I'm here with Grog helping me out with the material. As you know, I'm kind of dumb. I don't know. I'm just here to learn. And yeah, let's get it on. So, Krok, let's start with ischemic heart disease. Tell us what it is, why it's important to know what it is. Tell us how it differs from other kinds of heart disease.
Ischemic heart disease is when the heart muscle doesn't get enough blood and oxygen due to narrowed or blocked coronary arteries, often from plaque buildup, atherosclerosis, leading to symptoms like chest pain, angina, or heart attacks. It's critical to understand because it's a leading cause of death globally. Differs from other heart diseases, e.g., valvular or heart failure, by its focus on reduced blood flow and requires specific treatments like statins or stents to prevent severe outcomes. Want to dive into causes or compare it to interstitial lung disease next?
Um, well, so it's coronary. So it's the same as coronary heart disease or not?
Yes, ischemic heart disease, IHD, is essentially the same as coronary heart disease, CHD, as both refer to heart conditions caused by reduced blood flow to the heart muscle due to narrowed or blocked coronary arteries from atherosclerosis.
So what's the difference between that and cerebrovascular and peripheral?
Ischemic heart disease, IHD, cerebrovascular disease, and peripheral artery disease are all caused by atherosclerosis, plaque buildup narrowing arteries, but they affect different vascular beds. IHD involves the coronary arteries, reducing blood flow to the heart, causing angina or heart attacks. Cerebrovascular disease affects brain arteries, leading to strokes or transient ischemic attacks. And peripheral artery disease impacts limb arteries, causing leg pain or claudication. Their treatments overlap, e.g., statins, lifestyle changes, but specific interventions differ, e.g., stents for IHD, thrombolytics for stroke.
That makes sense.
Want to
So, tell me about cardiovascular disease in terms of its prevalence. Is it something that's a newer phenomenon?
Cardiovascular disease, CVD, including ischemic heart disease, is highly prevalent, affecting millions globally, e.g., WHO estimates 17.9 million deaths annually, mostly from IHD and stroke, driven by aging populations, obesity, diabetes, and smoking. But it's not a new phenomenon, as atherosclerosis has been found in ancient mummies, though modern lifestyles, sedentary behavior, processed foods, have amplified its incidence. Improved diagnostics and treatments, e.g., statins, bypass surgery, have reduced mortality in wealthier nations. But CVD remains a leading killer, especially in low-income regions. Want to dig into risk factors or historical trends?
I want to ask about the Framingham Heart Study.
The Framingham Heart Study, started in 1948 in Framingham, Massachusetts, is a landmark ongoing study that identified major risk factors for cardiovascular disease, CVD, like high cholesterol, hypertension, smoking, obesity, and diabetes, by following multiple generations and measuring their health outcomes over decades. It introduced the concept of risk factors and led to tools like the Framingham Risk Score, used to predict 10-year CVD risk, revolutionizing prevention and treatment strategies for ischemic heart disease and related conditions. Want to explore specific findings or its impact on modern cardiology?
Yes, I do.
Framingham heart studies findings include linking high LDL cholesterol, low HDL cholesterol, hypertension, smoking, diabetes, and physical inactivity to increased risk of ischemic heart disease, quantifying their impact through longitudinal data from thousands of participants. Its development of the Framingham Risk Score, which calculates 10-year cardiovascular risk based on age, sex, cholesterol, blood pressure, and smoking, transformed preventive cardiology by guiding lifestyle changes and treatments like statins, significantly reducing CVD mortality rates. Want to dive into how the risk score works or
I want to
explore?
ask about non-controllable risk factors. We have age, sex, family history. I mean, this is a tricky one because, I mean, how do we, when something is not under someone's control, how do we, like, how do we, as a doctor, do we say it to the patient? Do we, like, mention it? Because it's a bit disheartening, isn't it?
Non-controllable risk factors for ischemic heart disease include age, risk increases with older age, sex, men typically at higher risk earlier, women post-menopause, and family history, genetic predisposition to early CVD, which doctors should discuss sensitively with patients to inform risk assessment without causing despair, emphasizing that these factors only set a baseline. Communicating this involves framing it positively, highlighting controllable factors, diet, exercise, smoking cessation, that can offset genetic or demographic risks, and using tools like the Framingham Risk Score to tailor prevention plans, empowering patients rather than disheartening them. Want to explore how to discuss this with patients or dive into specific modifiable
Yeah, give us an
factors?
example. Why not?
When discussing non-controllable risk factors like family history with a patient, a doctor might say, "Your dad had a heart attack at 50, which raises your risk, but we can lower it significantly by managing your cholesterol with diet and maybe statins, plus regular exercise, giving you control over your heart health." This approach acknowledges the genetic risk, e.g., a male patient, age 40, with a strong family history of ischemic heart disease, while focusing on actionable steps like reducing LDL through plant-based meals and 30-minute daily walks. Using the Framingham
Okay,
Risk Score
that makes sense. So, okay, we mentioned already atherosclerosis, which is, tell us, it's basically fatty streak, it's lipid deposition, intimal fibrosis. Explain.
Atherosclerosis. Lipid deposition is the accumulation of LDL cholesterol, bad cholesterol, in the artery wall, where it gets oxidized and triggers inflammation, forming fatty streaks, early lesions made of lipid-loaded macrophages, foam cells, under the endothelium. Intimal
Okay,
fibrosis.
and this basically is the development of atherosclerosis.
Yep, exactly. Lipid deposition of LDL cholesterol in the artery wall, forming fatty streaks, followed by intimal fibrosis, with collagen and smooth muscle buildup, drives the development of atherosclerosis, narrowing arteries and causing ischemic heart disease.
So myocardial ischemia is the same as ischemic heart disease, or is it different?
Myocardial ischemia is a condition where the heart muscle, myocardium, gets insufficient blood flow and oxygen, typically due to narrowed coronary arteries from atherosclerosis, and is a core feature of ischemic heart disease, IHD. But IHD is the broader term encompassing chronic conditions like stable angina and acute events like myocardial infarction. While myocardial ischemia specifically describes the reduced perfusion episode, IHD includes all related syndromes caused by coronary
So
artery disease.
ischemic heart disease will result from myocardial ischemia.
Yes, ischemic heart disease, IHD, results in myocardial ischemia, as IHD involves narrowed coronary arteries from atherosclerosis that reduce blood flow to the heart muscle, causing ischemia, insufficient oxygen supply, which can manifest as angina or lead to heart attacks. Want to dive into how ischemia triggers symptoms?
Yeah,
Or link-
let's talk about anginas. Let's talk about stable and unstable and what's the difference. Let's perhaps talk a bit about acute coronary syndromes like NSTEMI, STEMI, and all of that. Explain us that. Yeah, we could. We've done so many episodes on heart failure, arrhythmia, sudden death. Let's do these for now, and yeah.
All right, let's dive into angina, stable versus unstable, and acute coronary syndromes, ACS, like STEMI and NSTEMI, keeping each in 2 to 3 sentences for clarity. Stable angina. Stable angina is chest pain or discomfort triggered by predictable exertion or stress, caused by myocardial ischemia from partially blocked coronary arteries, relieved by rest or nitroglycerin. It's a chronic symptom of ischemic heart disease, not immediately life-threatening, but signals underlying atherosclerosis. Unstable angina. Unstable angina involves sudden, worsening, or prolonged chest pain at rest or with minimal exertion due to a partially blocked coronary artery or plaque rupture, increasing heart attack risk. It's part of acute coronary syndromes, requiring urgent treatment like antiplatelets or catheterization.
Sorry, bro. Can you summarize in 2 3 sentences these two: stable, unstable, and STEMI, STEMI?
Stable angina is predictable chest pain from exertion due to partial coronary artery blockage, relieved by rest or nitroglycerin, indicating chronic ischemic heart disease. Unstable angina is sudden or worsening chest pain at rest, signaling plaque rupture and high heart attack risk, part of acute coronary syndromes. STEMI, ST, elevation myocardial infarction, and acute coronary syndrome, is a heart attack from complete coronary artery blockage, causing full thickness heart muscle damage, requiring immediate reperfusion like angiography. Want to dive into NSTEMI or quiz on these?
Yeah, dude. I mean, also STEMI, say it's ST elevation or whatever, myocardial infarction, whereas the other one is non-ST elevation. Explain to us why would we have the ST elevation in the first place?
STEMI, ST, elevation myocardial infarction, occurs when a coronary artery is completely blocked by a clot, usually from a ruptured atherosclerotic plaque, causing full-thickness heart muscle ischemia, which elevates the ST segment on an ECG due to severe injury currents from dying myocardial cells. In contrast, NSTEMI, non-ST elevation myocardial infarction, involves partial artery blockage, leading to subendocardial interlayer ischemia without ST elevation, showing different ECG changes like T-wave inversion or ST depression. The ST elevation in STEMI reflects the intense transmural damage, requiring urgent reperfusion like angiography to restore blood flow. Want to explore ECG differences further or dive into treatments?
Tell me again. To be honest, I'm confused with this STEMI, STEMI, whatever.
No worries, let's clarify. STEMI, ST, elevation myocardial infarction, is a severe heart attack caused by a completely blocked coronary artery, typically from a clot on a ruptured plaque, leading to full-thickness heart muscle damage, which causes ST segment elevation on an ECG due to intense electrical changes from dying cells. NSTEMI, on the other hand, involves a partial blockage, damaging only the inner heart muscle layer.
So
without
angina, stable angina would be an STEMI then, and non-stable would be STEMI. The other question I have, why ST? So the QRS complex is the ventricular depolarization, I think. So QRS, then ST would be what? What part of the kind of cardiac cycle is the ST?
You're mixing up a few concepts, so let's clarify stable, unstable angina, and STEMI, NSTEMI. Then address why it's called ST and its role in the cardiac cycle. Clarification on angina versus STEMI, NSTEMI. Stable angina is not NSTEMI. It's chronic chest pain from partial coronary artery narrowing, triggered by exertion and relieved by rest, with no heart muscle damage. Unstable angina isn't STEMI either. It's worsening or rest-related chest pain, part of acute coronary syndromes, ACS, indicating high heart attack risk, but not necessarily infarction. STEMI, ST elevation myocardial infarction, and NSTEMI, non-ST elevation myocardial infarction, are actual heart attacks with muscle damage. STEMI from complete artery blockage, causing ST elevation on ECG, and NSTEMI from partial blockage. No ST elevation, but other ECG changes. Why ST and cardiac cycle? The ST segment on an ECG follows the QRS complex, ventricular depolarization, when ventricles contract, and represents the early phase of ventricular repolarization, when ventricles start to relax before the T wave completes repolarization. In STEMI, ST elevation occurs because severe ischemia from a blocked artery alters the electrical potential across the myocardium, creating injury currents visible as an elevated ST segment. Unlike stable angina, which typically shows normal ECG or minor changes during stress. Want to dive into ECG interpretation or quiz on angina versus
Yeah,
ACS?
let's do the quiz. Let's do the quiz, and also explain to us, dude, what part of the cycle is the ST? Is it when the ventricles? It's not when the ventricles relax. What part of it is it? Hyperpolarization? I don't remember.
All right, let's tackle your question about the ST segment's role in the cardiac cycle first. Then jump into a quick quiz on ischemic heart disease for you and the podcast crew, keeping answers 1 or 2 words. ST segment in cardiac cycle. The ST segment on an ECG occurs right after the QRS complex, ventricular depolarization, when ventricles contract, and represents the early phase of ventricular repolarization, when the ventricles are starting to relax but aren't fully repolarized, not hyperpolarization, which happens later in cell recovery. In STEMI, ST elevation reflects injury from ischemia, not a normal cycle phase. Quiz time. Rapid fire, ischemic heart disease. 1. Cause of ischemic heart disease.
Coronary artery blockage.
Spot on. Coronary artery blockage it is. Next. 2. Symptom of stable angina.
Basically, you have to exert. There has to be some kind of exertion to have the pain.
Good, but let's keep it 1 or 2 words. Exertional chest pain. All right. 3. ECG sign of STEMI.
ST elevation.
Nailed it.
All right.
ST elevation.
Okay, so so let's talk about the classification of chest pain then. So we have a typical angina, we have an atypical angina, we have a non-anginal chest pain. So let's say we have, I think we have 3 characteristics, right? So we have the exertion or stress, and then that's 1, and then we have if it's relieved by rest or nitrates, it might be angina, and then What's the last one? Substernal chest discomfort or characteristic quality and duration. What's that different by? I guess that's the main one. Yeah.
You're right about classifying chest pain for ischemic heart disease, and the three characteristics used to define typical, atypical, and non-anginal chest pain are key for diagnosing angina. Here's the breakdown. 3 characteristics of angina. 1. Substernal chest discomfort with a characteristic quality and duration, e.g., pressure, squeezing, lasting minutes, not seconds or hours. 2. Provoked by exertion or emotional stress. 3. Relieved by rest or nitroglycerin. Classification. Typical angina meets all 3 criteria: substernal pain, exertion triggered, relieved by rest nitrates, highly suggestive of ischemic heart disease. Atypical angina meets 2 of the 3 criteria, e.g., substernal pain and exertion but not relieved by rest, or exertion and relief but not typical location. Less certain but still concerning. Non-anginal chest pain meets 1 or none of the criteria, e.g., sharp, fleeting pain unrelated to exertion, unlikely to be angina, often musculoskeletal or gastrointestinal. The substernal characteristic is critical as it points to the heart's location and ischemic pain's typical, heavy, squeezing nature, distinguishing it from sharper, non-cardiac pain. Want to explore how these guide diagnosis or jump back to the quiz?
No, that's good. Let me ask you about what's this? So we have CABG and PCL. What is this, like some kind of management of stable angina? Can you explain it to us? Would calcium channel blockers help or beta blockers?
You're referring to CADG, likely coronary artery disease
No,
guidelines.
CABBG, B for Bob. Coronary artery bypass graft. And percutaneous coronary intervention. PCI.
Got it, my bad. You meant CABG, coronary artery bypass graft, and PCI, percutaneous coronary intervention. Key man.
Yeah.
All right, let's dive into managing stable ANGA, focusing on what CADG, coronary artery disease
Sir. No, you got confused. We said percutaneous coronary intervention. We said calcium channel blockers, beta blockers. We said just a sec. Bypass grafting.
My bad for the mix-up. Let's clarify. You're asking about managing stable ANGA with percutaneous coronary intervention, PCI, coronary artery bypass grafting, CABG, calcium channel blockers, and beta blockers. Here's the rundown. Percutaneous coronary intervention, PCI. PCI involves inserting a stent via catheter to open a narrowed coronary artery. Used in stable ANGA when symptoms persist despite medications, improving blood flow to reduce chest pain but not always reducing heart attack risk. Coronary artery bypass grafting, CABG. CABG surgically reroutes blood flow around blocked coronary arteries using grafts. Examples from leg veins. reserved for severe stable anga with multiple vessel disease or left main artery stenosis, offering longer-term symptom relief than PSI in complex cases. Calcium channel blockers, example, amlodipine. These relax coronary and systemic arteries,
So what is
reducing
the
heart work.
bypass grafting? Is it when we get like a vein from the leg?
Yes, coronary artery bypass grafting, CABG, involves taking a vessel, often the saphenous vein from the leg, or an artery, like the internal mammary artery, and surgically grafting it to reroute blood flow around a blocked coronary artery, restoring blood supply to the heart muscle in severe stable anga or complex ischemic heart disease.
And why is it an acute coronary syndrome and not a chronic one? Why is unstable angina an acute problem? And STEMI, why are they acute?
Unstable anga, STEMI, ST elevation myocardial infarction, and NSTEMI, non-ST elevation myocardial infarction, are classified as acute coronary syndromes, ACS, because they involve sudden, critical reductions in coronary blood flow due to plaque rupture or clot formation, requiring urgent intervention to prevent heart muscle damage or death, unlike stable anga, which is chronic and predictable. Unstable anga causes severe, unpredictable.
That makes sense. Okay. And why do we have a rise in troponin when we have a myocardial infarction?
Troponin levels rise during a myocardial infarction, STEMI or NSTEMI, because heart muscle cells, cardiomyocytes, are damaged or died due to prolonged ischemia from a blocked coronary artery, releasing troponin, a protein specific to cardiac muscle, into the bloodstream.
But it's only released when there's death.
Not exactly. Troponin can be released during myocardial infarction, STEMI or NSTEMI, from both heart muscle cell death and severe injury without complete necrosis, as ischemia damages cell membranes, allowing troponin, a cardiac-specific protein, to leak into the bloodstream. Elevated troponin levels, detected via blood tests, are thus a sensitive marker of myocardial damage.
But it's not released in unstable angina, and I don't understand why. Also, before I asked you and you said I got confused. Regarding to STEMI and NSTEMI, it sounds to me more likely that with unstable angina, I will have STEMI rather than NSTEMI. Is this true? And it seems to me more likely that in stable angina, I will have STEMI. Sorry, I will have the NSTEMI more likely than STEMI.
Let's address your two questions clearly. Why troponin isn't released in unstable angina, and whether unstable angina is more likely to lead to STEMI than NSTEMI, and if stable angina predisposes to NSTEMI over STEMI. NSTEMI in unstable angina. Troponin is typically not elevated in unstable angina because, unlike STEMI or NSTEMI, it involves transient ischemia without significant heart muscle cell damage or death. So cardiac troponin proteins don't leak into the bloodstream, though unstable angina can still be serious as it signals plaque instability. STEMI versus NSTEMI with unstable stable angina. Unstable angina, as part of acute coronary syndromes, is more likely to progress to either STEMI or NSTEMI, not specifically one over the other, depending on whether the plaque rupture causes complete STEMI or partial NSTEMI, coronary artery occlusion. Stable angina, being chronic, doesn't directly predispose to NSTEMI over STEMI, but reflects underlying atherosclerosis.
I got that part of the question. So tell me now about the troponin thing. Why don't we see troponin levels elevated in unstable angina?
Troponin levels are not elevated in unstable angina because it involves temporary myocardial ischemia from a partially blocked or spasming coronary artery, causing chest pain without sufficient heart muscle cell damage or death to release troponin into the bloodstream. In contrast, STEMI and NSTEMI involve prolonged ischemia leading to cell injury or necrosis, releasing troponin, making it a key marker to distinguish unstable angina from myocardial infarction. Want to explore troponin testing or dive into other ACS diagnostics?
I don't get the reasoning, to be honest.
Alright, let's simplify. Troponin levels stay normal in unstable angina because the heart muscle experiences only brief ischemia, reduced blood flow, from a temporary or partial coronary artery blockage, not enough to damage or kill heart cells. So no troponin, a protein inside heart cells, leaks into the...
I see. So let me ask you another question then. So if I have an unstable angina really, really close to the heart, would that change things?
When you say unstable angina really close to the heart, I'm assuming you mean a blockage in a critical coronary artery near the heart's main blood supply.
Yes.
Alright, if unstable angina involves a blockage in a critical coronary artery close to the heart's main blood supply, like the left main or proximal left anterior descending artery, it doesn't change the lack of troponin elevation, since unstable angina still avoids significant heart muscle damage, but it increases the risk of progressing to STEMI or NSTEMI, due to the larger area of heart muscle at risk, requiring urgent intervention like PCI or CABG. The severity of the location heightens the urgency, but doesn't alter the troponin distinction from myocardial infarction. Want to explore these high-risk blockages or quiz on ACS?
I want to ask you about, can we see ST depression too, instead of ST elevation?
Yes, ST depression can be seen in unstable angina or NSTEMI, non-ST elevation myocardial infarction, on an ECG, reflecting subendocardial ischemia, reduced blood flow to the inner heart muscle layer, due to partial coronary artery blockage. Unlike ST elevation in STEMI, which indicates full-thickness ischemia from complete blockage, ST depression, along with T-wave inversion, suggests myocardial strain or injury, but is less specific than ST elevation for acute infarction, often prompting further tests like troponin levels to differentiate unstable angina from NSTEMI.
But what would an ST depression mean?
ST depression on an ECG indicates subendocardial ischemia, where the inner layer of the heart muscle gets insufficient blood flow due to a partial coronary artery blockage, commonly seen in unstable angina or NSTEMI, reflecting strain or injury, but not full-thickness heart muscle damage like in STEMI's ST elevation. It suggests the heart is stressed, often requiring urgent evaluation with troponin tests or angiography to determine if it's acute coronary syndrome or another issue. Want to dive into how ST depression is diagnosed?
I'm confused.
No worries, let's clear it up. ST depression on an ECG means the inner heart muscle layer, subendocardium, isn't getting enough blood and oxygen due to a partially blocked coronary artery, causing a downward shift in the ST segment, seen in unstable angina or NSTEMI. Unlike ST elevation, which signals a complete blockage damaging the full heart wall in STEMI. It's a sign of heart stress, not necessarily infarction.
But why is the depression? Why doesn't it just stay normal? What's the difference between the ST being normal versus depression?
ST depression occurs because partial coronary artery blockage causes subendocardial ischemia, altering the electrical repolarization of the inner heart muscle, which shifts the ST segment below the baseline on an ECG due to injury currents, whereas a normal ST segment indicates no significant ischemia with balanced electrical activity during early ventricular repolarization. The difference stems from the degree of blood flow reduction. Normal ST means adequate oxygen supply, while depression reflects stressed, oxygen-deprived subendocardial tissue, common in unstable angina or NSTEMI. Want to explore ECG?
I don't get this difference.
Alright, let's simplify. A normal ST segment on an ECG means the heart muscle has enough blood and oxygen, so the electrical activity during early ventricular repolarization, after contraction, stays balanced, showing a flat ST line. ST depression happens when a partially blocked coronary artery reduces blood flow to the inner heart muscle, subendocardium, causing ischemia that disrupts repolarization, creating electrical imbalances that pull the ST segment below the baseline, seen in unstable angina or NSTEMI.
Dude, I'm so confused. Tell me what you just said again.
No stress. Let's break it down again. A normal ST segment on an ECG is flat because the heart muscle gets enough blood and oxygen, keeping electrical repolarization post-contraction phase balanced. ST depression shows as a downward dip when a partial coronary artery blockage starves the inner heart muscle of oxygen, causing ischemia that messes up repolarization.
Alright, never mind. Okay. So, we'll come back to it. Remind me in 10 minutes, okay? So, interstitium of the lung. Like, what is this? Let's go to our other topic.
Alright, I'll remind you about ST depression in 10 minutes. And now let's dive into interstitial lung disease, ILD, also called diffuse parenchymal lung disease. ILD is a group of disorders causing inflammation and scarring, fibrosis, in the lung's interstitial tissue, the space around air sacs, leading to stiff lungs, reduced oxygen exchange, and symptoms like shortness of breath and dry cough, distinct from ischemic heart disease, as it affects lung tissue.
So, interstitium of the lung is the space around the air sacs. What about connective tissue and blood and lymph vessels?
The interstitium of the lung includes the space around the air sacs, alveoli, encompassing connective tissue, blood vessels, and lymph vessels, which support the lung's structure and facilitate gas exchange. In interstitial lung disease, ILD, inflammation or scarring in this interstitial space, including these components, stiffens the lungs, impairing oxygen transfer, causing symptoms like dyspnea, unlike ischemic heart disease, which involves coronary artery blockage. Want to explore ILD causes or connect it to heart disease? Reminders set for ST depression in approximately 10 minutes.
So what exactly is the interstitium then? So it involves a lot of things. So what does it not involve then? What's the etymology of interstitium?
The interstitium of the lung is the supportive tissue between the air sacs, alveoli, including connective tissue, blood vessels, lymphatics, and extracellular matrix, but it does not include the alveolar epithelium, air sac linings, or the air spaces themselves where gas exchange occurs. In interstitial lung disease, this interstitium gets inflamed or scarred, stiffening the lungs, unlike the heart's vascular issues in ischemic heart disease. The term interstitium comes from Latin interstitium, meaning between spaces, from inter, between, and star, to stand, describing the tissue standing between functional lung units. Want to dive into ILD subtypes or revisit ischemic heart disease? ST depression reminder.
So it's the kind of interstitium is like the in-between. So what does it not? What does it not include?
The lung interstitium includes connective tissue, blood vessels, lymphatics, and extracellular matrix between the alveoli, but it does not include the alveolar epithelium, the cells lining the air sacs, the air spaces inside the alveoli where gas exchange happens, or the bronchial airways. In interstitial lung disease, only this interstitial tissue gets inflamed or scarred, affecting lung function, distinct from airway-focused diseases like asthma. ST
Okay,
depression.
let's talk a bit more about the connective tissue spaces of the lung. Let's talk about the intralobular septa and the it's the interlobular septa too.
The connective tissue spaces of the lung, part of the interstitium, include the intralobular septa and interlobular septa, which are key in interstitial lung disease, ILD, and distinct from ischemic heart disease's vascular pathology. Intralobular septa. These are thin connective tissue sheets within lung lobules surrounding alveoli and containing capillaries and lymphatics supporting gas exchange. In ILD, inflammation or fibrosis here stiffens the lung, reducing oxygen diffusion. Interlobular septa. These thicker connective tissue partitions separate lung lobules, housing larger blood vessels, lymphatics, and veins. ILD-related scarring in these septa can cause traction on airways, worsening breathlessness. In ILD, both septa types can thicken due to fibrosis or inflammation, unlike the coronary artery issues in ischemic heart disease. ST depression reminder in approximately 4 minutes. Want to dive into ILD?
Tell me again the difference between interlobular and intralobular.
Intralobular septa are thin connective tissue sheets within lung lobules, encasing alveoli and capillaries, aiding gas exchange, and are affected by fibrosis in interstitial lung disease, causing lung stiffness. Interlobular septa are thicker partitions between lobules, containing larger vessels and lymphatics, and their scarring in ILD can distort airways, worsening breathing issues. ST depression reminder in approximately 2 minutes. Want to explore their role in ILD diagnostics?
So the intralobular septa is around the alveoli and there is a thin layer between the alveoli and the capillaries. Whereas the interlobular outline the secondary lobules. These and they contain the lymphatics and the veins of the lungs. So wait, I'm a bit confused. Could you kind of explain to us, like, are the intra inside of the inter or the other way around?
You're close, but a bit tangled up. So let's clarify the intralobular and interlobular septa. Intralobular septa are thin connective tissue layers inside lung lobules, surrounding alveoli and capillaries, facilitating gas exchange, while interlobular septa are thicker connective tissue walls that outline and separate secondary pulmonary lobules, containing lymphatics, veins, and larger vessels. The intralobular septa are within each lobule, nested inside the
So the
boundaries.
inter, they are bigger, they're inside, they're intra. And the inter, they are, the intra, they are smaller, the inter, they are bigger.
You're getting there. Intralobular septa are smaller, thinner connective tissue layers inside each secondary pulmonary lobule, surrounding alveoli and capillaries, while interlobular septa are larger, thicker walls that surround and separate entire secondary lobules, containing lymphatics and veins. It's not that one is inside the other. Intralobular septa are within lobules, and interlobular septa encase them, forming lobule boundaries.
And what is peribronchial interstitium?
The peribronchial interstitium is the connective tissue surrounding the bronchi and bronchioles in the lung, part of the lung's interstitial network, containing blood vessels, lymphatics, and nerves, supporting airway structure, but distinct from intralobular and interlobular septa, which focus on alveolar and lobular regions. In interstitial lung disease, inflammation or fibrosis in the peribronchial interstitium can contribute to airway distortion and breathing difficulties.
What is peribronchial, and explain it to me relative to something else too.
The peribronchial interstitium is the connective tissue layer surrounding the bronchi and bronchioles, containing blood vessels, lymphatics, and nerves, providing structural support to the lung's airways, distinct from the alveolar-focused intralobular septa or lobule-separating intralobular septa. Relative to the intralobular septa, which are delicate tissues encasing alveoli and capillaries within lobules for gas exchange, the peribronchial interstitium is thicker and airway-centric. And in interstitial lung disease, its fibrosis can stiffen airways, worsening breathlessness, unlike the coronary artery issues in ischemic heart disease. Want to compare it to another lung structure?
Bro, I'm really confused, to be honest. What is this peribronchial? What's the difference between peribronchial and other types of bronchial? Explain to me in a sentence or two.
The peribronchial interstitium is the connective tissue surrounding the bronchi and bronchioles, supporting airways with vessels and nerves, unlike intralobular septa, within lobules around alveoli.
And the secondary lobules, they are the smallest functional unit that contains a central artery and a terminal bronchiole and is bound by a fibrous connective tissue. I have one question about all of this. Why? How does the name relate to the structure? How does the structure relate to the function? How did we even come to know that? How did we name it?
You're diving deep into the secondary pulmonary lobule, its naming, structure, function, and how we came to understand it. So let's break it down clearly. Secondary pulmonary lobule. This is the smallest functional unit of the lung, surrounded by connective tissue, interlobular septa, typically 2.5 centimeters, containing a central artery, terminal bronchiole, and surrounding alveoli, bound by fibrous septa with lymphatics and veins, crucial for gas exchange and interstitial lung disease, distinct from ischemic heart disease's vascular focus. Why the name? The term lobule comes from Latin lobulus, small lobe, reflecting its role as a smaller subdivision of the lung's lobes, and secondary indicates it's a subunit of the primary lobule, a vaguer, larger anatomical term. Pulmonologists like Miller in the 20th century named it based on histological and radiological studies, showing its distinct boundaries. Structure-function relation. The lobule's structure, central...
Yeah, tell me again, the last bit you said?
The peribronchial interstitium is connective
No,
tissue
dude.
around...
We're talking about the secondary lobules, and I asked you some questions about how the name relates to the structure and the function, and who named it, and who discovered it, and how did we come to these conclusions and all of that.
My bad. I missed your earlier cue about secondary pulmonary lobules.
Yeah, get to
Let's
the point and answer to me in 2-3 sentences. Don't do introductions. Straight in.
Secondary pulmonary lobules, named for their role as functional lung units supplied by a bronchiole and arteriole, were described by anatomists like William Ewart in the 19th century based on cadaveric lung dissections. Interlobular septa, outlining these lobules, and intralobular septa within them, were defined through histological studies, with their names reflecting their anatomical position relative to lobular structure. Their function in gas exchange and ILD pathology was confirmed via microscopy and imaging advancements. Want to dive into their discovery details?
Let's go back and do the... You remember we had a reminder to talk about some STEMI stuff. Let's do that. The difference between the depression and the elevation, basically.
ST elevation in STEMI occurs on an ECG when a completely blocked coronary artery causes full-thickness heart muscle ischemia, creating strong injury currents that raise the ST segment above the baseline, indicating a severe heart attack needing urgent reperfusion. ST depression seen in unstable angina, or NSTEMI, reflects partial coronary blockage causing subendocardial ischemia, producing weaker electrical shifts that lower the ST segment below the baseline, signaling less severe but still serious heart stress. Want a quiz on ECG signs or explore treatments?
I just don't understand the depression. It sounds more logical to me to have an elevation and a less high elevation rather than suddenly we go 180 degrees to the other side.
The confusion about ST depression versus elevation comes from their distinct electrical mechanisms. ST elevation in STEMI happens because complete coronary blockage causes intense, full-thickness myocardial injury, generating strong upward electrical currents, injury currents, that lift the ST segment on the ECG. ST depression in unstable angina, or NSTEMI, occurs with partial blockage, causing subendocardial ischemia that creates opposite, downward electrical shifts due to altered repolarization in the inner heart layer.
Subendocardial ischemia. What is this?
All right. You want to pause and do some cardio? Or you mean let's stick with cardiology?
Fucking hell, dude. I asked, what's this subendocardial ischemia, whatever you said?
My bad. Let's clear it up. Subendocardial ischemia, seen in unstable angina, or NSTEMI, is when the inner layer of the heart muscle, subendocardium, gets insufficient blood flow due to a partially blocked coronary artery, causing ST depression on an ECG because of altered electrical repolarization in that layer. Unlike STEMI's full-thickness ischemia, causing ST elevation, subendocardial ischemia is less severe but still serious, often requiring antiplatelet drugs or angiography. Want to dive into why it causes depression or quiz on this?
Antiplatelet drugs. Fuck it, dude. No. But so one does a big elevation, the other does a depression. So we don't have subendocardial ischemia in ST elevation then.
You're right to question this. In STEMI, ST elevation myocardial infarction, the ischemia is transmural, full thickness, affecting the entire heart muscle wall, caused by a completely blocked coronary artery, generating strong injury currents that elevate the ST segment on an ECG. In contrast, unstable angina, or NSTEMI, causes subendocardial ischemia, only the inner heart muscle layer due to partial blockage, producing weaker, opposite electrical shifts that cause ST depression. STEMI doesn't typically involve just subendocardial ischemia.
Fair enough. Okay, let's continue with the ischemic heart disease. So, let's talk a bit about the pathological progression to atherothrombosis.
Atherothrombosis in ischemic heart disease begins with atherosclerosis, where LDL cholesterol deposits in the arterial intima form fatty streaks, progressing to fibrotic plaques with a lipid core and fibrous cap. Plaque rupture or erosion triggers thrombus, clot formation, driven by exposed collagen and tissue factor, which can partially or fully block coronary arteries, causing unstable angina, NSTEMI, or STEMI.
And we have adherence, activation, aggregation of platelets. Then we have prothrombin to thrombin, fibrinogen to fibrin, yeah?
You're spot on with the clotting cascade in atherothrombosis for ischemic heart disease. After plaque rupture, platelets adhere to exposed collagen in the artery wall, activate and aggregate to form a platelet plug, while simultaneously, prothrombin is converted to thrombin, which transforms fibrinogen into fibrin, stabilizing the clot. This thrombus can partially or fully obstruct the coronary artery, leading to unstable angina, NSTEMI, or STEMI, depending on the degree of occlusion. Want to explore the role of antiplatelet drugs?
I want to ask about this ACS in regard to the classical symptoms. Why do we have radiation of pain?
In acute coronary syndromes, ACS, like unstable angina, NSTEMI, or STEMI, the classical symptom of chest pain often radiates to the left arm, jaw, neck, or back because ischemic heart muscle activates visceral pain fibers that share spinal nerve pathways, T1, T5, with somatic nerves in these areas, causing referred pain. This radiation occurs due to the brain misinterpreting the pain's origin, a common feature distinguishing cardiac pain from non-cardiac causes. Want to explore other ACS symptoms?
And why? So ACS is atherothrombosis.
Acute coronary syndromes, ACS, including unstable angina, NSTEMI, and STEMI, are often caused by atherothrombosis, where an atherosclerotic plaque ruptures and forms
caused by it. But so if you use GTN, is it going to relieve the pain immediately or no?
Glyceryl trinitrate, GTN, or nitroglycerin, typically relieves chest pain in acute coronary syndromes, ACS, like unstable angina, within minutes, by dilating coronary arteries to improve blood flow to ischemic heart muscle and reducing heart workload through vasodilation. However, in STEMI or NSTEMI, GTN may provide partial or no relief if the pain is due to significant infarction from a fixed obstruction, requiring reperfusion therapies like PCI. Want to explore GTN's mechanism or other ACS treatments?
That makes sense. No, but I'm wondering how we assess the patients then, if they have, if we suspect they have acute coronary syndrome.
To assess suspected acute coronary syndrome, ACS, clinicians use a combination of clinical history, chest pain characteristics, radiation, duration.
Stress test. Yeah.
All right, sticking with assessing acute coronary syndrome, ACS, clinicians prioritize a detailed history of chest pain, substernal, exertional, or at rest, an ECG within 10 minutes to detect ST elevation, depression, or T-wave changes, and blood tests for cardiac biomarkers, like troponin, to confirm myocardial injury. guiding urgent treatment decisions like antiplatelets or PCI. Want to dive into specific ECG
Wait,
findings?
acute coronary syndrome doesn't automatically mean elevated troponin.
You're correct. Acute coronary syndrome, ACS, doesn't always mean elevated troponin. Unstable angina, a type of ACS, typically has normal troponin levels because it involves transient ischemia without heart muscle damage, whereas STEMI and NSTEMI show elevated troponin due to myocardial injury or necrosis.
Yeah.
Assessment still relies on history, chest pain radiating to arm, jaw, ECG, ST changes, or T-wave inversion. And
Okay, so
troponin.
how would clopidogrel, prasugrel, and ticagrelol help?
Clopidogrel and ticagrelor are antiplatelet drugs used in acute coronary syndromes, ACS, to prevent further thrombus formation by inhibiting platelet activation and aggregation, with clopidogrel blocking the P2Y12 receptor to reduce clot growth, and ticagrelor, a more potent P2Y12 inhibitor, acting faster and reversibly to stabilize plaques and lower heart attack risk. They are often combined with aspirin in unstable angina, NSTEMI, or STEMI to improve blood flow and prevent stent thrombosis post-PCI, but carry bleeding risks.
And how does their name relate to their function?
Clopidogrel's name doesn't directly reflect its function, but is derived from its chemical structure, plus A-thienopyridine. While its role as an antiplatelet drug comes from inhibiting the P2Y12 receptor on platelets, preventing aggregation and thrombus growth in ACS. Ticagrelor's name also stems from its chemical class, cyclopentyltriazolopyrimidine, and its function as a reversible P2Y12 inhibitor reduces platelet activation, stabilizing clots in unstable angina or myocardial infarction. Want to explore their chemical mechanisms or compare their efficacy?
Not really. But I would want to ask about prasugrel, which we didn't mention much. Actually, yeah, compare them too. Why not? Maybe we learn something.
Prasugrel, clopidogrel, and ticagrelor are P2Y12 inhibitor antiplatelet drugs used in acute coronary syndromes, ACS, to prevent thrombus formation, but they differ in potency, speed, and risks. Prasugrel, a thienopyridine, irreversibly blocks the P2Y12 receptor, acting faster and more potently than clopidogrel, reducing stent thrombosis in STEMI or NSTEMI post-PCI, but its higher bleeding risk limits use in elderly or low-weight patients. Clopidogrel, also a thienopyridine, irreversibly inhibits P2Y12 but is less potent and slower due to variable metabolism, making it a standard choice for ACS but less effective in some patients. Ticagrelor, a cyclopentyltriazolopyrimidine, reversibly binds P2Y12, offering rapid, potent action with lower heart attack risk than clopidogrel.
So with ST elevation myocardial infarction, why do we give antiplatelet agents? Platelets leads to clotting. We don't want clotting because we want blood flow.
In ST elevation myocardial infarction, STEMI, antiplatelet agents like prasugrel, clopidogrel, or ticagrelor are given to inhibit platelet activation and aggregation, preventing further clot, thrombus, growth at the site of a ruptured plaque, which could worsen the complete coronary artery blockage. By reducing clotting, these drugs improve blood flow, stabilize the plaque, and lower the risk of additional heart muscle damage or stent thrombosis post-PCI, complementing urgent reperfusion therapies. Want to explore how they work with aspirin or dive into reperfusion?
How does aspirin help?
Aspirin helps in acute coronary syndromes like STEMI by irreversibly inhibiting cyclooxygenase 1, COX1, in platelets, reducing thromboxane A2 production, which prevents platelet aggregation and clot formation, thereby improving coronary blood flow and stabilizing ruptured plaques. Given early, e.g., 325 mg chewed dose, it complements P2Y12 inhibitors, clopidogrel, ticagrelor, prasugrel, to further reduce the risk of additional thrombosis, heart attack, or death.
Okay,
With
so
minimal-
we have the two branches of the right and left coronary arteries branching of the ascending aorta. So where do they go after that, these coronary arteries?
The left coronary artery, branching from the ascending aorta, divides into the left anterior descending LAD artery, which supplies the front of the left ventricle and septum, and the circumflex artery, which supplies the left atrium and lateral left ventricle. The right coronary artery, also from the ascending aorta, supplies the right atrium, right ventricle, and often the posterior septum and inferior left ventricle via the posterior descending
Wait, I guess
artery.
step by step. So let's start from top. We have left coronary and right coronary. What happens then?
Starting from the top, the left coronary artery and right coronary artery arise from the ascending aorta just above the aortic valve at the coronary ostia. The left coronary artery splits into the left anterior descending LAD artery, supplying the front of the left ventricle and septum, and the circumflex artery, supplying the left atrium and lateral left ventricle, while the right coronary artery supplies the right atrium, right ventricle, and often the posterior septum and inferior left ventricle.
So the right coronary artery doesn't break down to a circumflex and an anterior descending.
Correct. The right coronary artery does not branch into a circumflex or anterior descending artery. It primarily runs along the right heart border, supplying the right atrium, right ventricle, and often the posterior septum.
And why do we have this asymmetrical situation then?
The asymmetry between the left and right coronary arteries arises from their embryological development and the heart's functional anatomy. The left coronary artery splits into the left anterior descending, LAD, and circumflex to supply the larger, high-pressure left ventricle, which pumps blood to the systemic circulation, requiring more blood flow. The right coronary artery, supplying the smaller, lower-pressure right ventricle and parts of the septum, doesn't need such extensive branching, reflecting the heart's
So what
workload.
branches does the right coronary artery have?
The right coronary artery, RCA, has several key branches. The conus artery, supplying the right ventricular outflow tract, the sinoatrial nodal artery, supplying the SA node in 60% of people.
Okay. Let's talk a bit about stenting and balloon angioplasty.
Balloon angioplasty and stenting are key interventions for ischemic heart disease, particularly in acute coronary syndromes like STEMI or unstable angina, to restore coronary artery blood flow. Balloon angioplasty. A catheter with an inflatable balloon is inserted into the narrowed coronary artery and inflated to compress the atherosclerotic plaque, widening the vessel to improve blood flow, often used as a precursor to stenting, but carries a higher risk of vessel re-narrowing, restenosis. Stenting. After angioplasty, a metal mesh stent, often drug-eluting, is placed in the artery to keep it open, significantly reducing restenosis compared to angioplasty alone, with antiplatelet drugs like aspirin and ticagrelor given to prevent stent thrombosis. Both procedures, done via percutaneous coronary intervention, PCI, are guided by angiography and are critical in STEMI to save heart muscle, though stenting is now preferred for its durability. Want to explore their risks or compare to CAB-EG?
Can you explain to me why troponin increase is not synonymous with non-ST elevation, myocardial infarction?
Troponin increase is not synonymous with non-ST elevation myocardial infarction, NST-EMI, because elevated troponin indicates heart muscle injury, which can occur in NST-EMI due to partial coronary artery blockage causing subendocardial damage, but also in other conditions like STEMI, myocarditis, or non-cardiac issues, e.g., renal failure,
I see.
sepsis.
I see. That makes sense. Okay, so how do we manage NSTEMI? Analgesia. Talk to us about analgesia and the therapies and stuff. Maybe coronary angiography.
Managing NST-EMI, non-ST elevation myocardial infarction, involves analgesia, anti-ischemic therapies, anticoagulation, and often coronary angiography to address the partial coronary artery blockage causing subendocardial ischemia. Analgesia. Morphine or other opioids are used to relieve severe chest pain in NST-EMI, reducing patient distress and heart workload, though nitroglycerin is also given to dilate coronary arteries and ease pain unless contraindicated, e.g., low blood pressure. Anti-ischemic and antithrombotic therapies. Beta blockers, e.g., metoprolol, and nitroglycerin reduce heart oxygen demand, while antiplatelet drugs, aspirin, ticagrelor, and anticoagulants, heparin and oxyparin, prevent further clot growth, stabilizing the plaque. Coronary angiography. Performed within 72 to 72 hours in most NST-EMI cases, angiography visualizes coronary blockages, guiding decisions for percutaneous coronary intervention, PCI, with stenting or rarely coronary artery bypass grafting, CABG, based on the extent of artery narrowing. Want to dive into specific drug dosing or PCI timing?
No, it's good. I want us to go back to another topic of interstitial lung disease. So we mentioned the secondary lobules. Let's talk a bit about diseases which cause scarring. So interstitial lung diseases. Yeah.
Interstitial lung diseases, ILDs, causing scarring, fibrosis, affect the lung interstitium, including secondary pulmonary lobules, leading to stiffened lungs and impaired gas exchange, distinct from ischemic heart disease. Key fibrotic ILDs include idiopathic pulmonary fibrosis, IPF, where progressive scarring of intralobular and interlobular septa causes severe dyspnea and cough, and connective tissue disease-associated ILD, e.g. from rheumatoid arthritis, which also fibroses the interstitium, often with peribronchial involvement. These diseases, diagnosed via CT showing honeycombing or ground glass opacities, differ from airway diseases like COPD and are managed with antifibrotics, e.g. perfenadine for IPF or immunosuppressants, but prognosis varies widely. Want to explore specific ILD causes or their imaging features?
So let's talk about the types of inflammatory lesions that we might notice and the types of fibrosis, shall we?
Interstitial lung diseases, ILDs, feature various inflammatory lesions and types of fibrosis affecting the lung interstitium, including secondary lobules, distinct from ischemic heart disease. Inflammatory lesions. These include ground glass opacities, seen on CT as hazy areas from alveolar inflammation, Common in early ILD, like hypersensitivity pneumonitis. Consolidation. Dense alveolar filling in acute ILDs, like cryptogenic organizing pneumonia. And nodules. Small interstitial granulomas in sarcoidosis, reflecting active inflammation in intralobular or peribronchial interstitium.
Okay, let's talk a bit about granulomas. How are they connected to all of this?
Granulomas in interstitial lung disease, ILD, are small, organized clusters of immune cells, macrophages, lymphocytes, forming in the lung interstitium, often in intralobular septa or peribronchial areas, as a response to chronic inflammation, seen in ILDs like sarcoidosis or hypersensitivity pneumonitis, but not in fibrotic ILDs like idiopathic pulmonary fibrosis. They contribute to ILD by causing nodular lesions that impair gas exchange, visible on CT as scattered opacities, and differ from ischemic heart disease's vascular pathology.
What are opacities? And I still don't understand these granulomas. So they are a collection of macrophages?
Opacities on a CT scan in interstitial lung disease, ILD, are areas of increased density, appearing as hazy, ground glass, solid, consolidation, or nodular patterns, indicating inflammation, fibrosis, or granulomas in the lung interstitium. Unlike ischemic heart disease's vascular issues, granulomas are indeed collections of macrophages, often with lymphocytes, forming tight, organized nodules in the interstitium, e.g., intralobular septa, due to chronic immune responses in ILDs like sarcoidosis, triggered by antigens or unknown causes, disrupting lung function by occupying space and causing inflammation.
Okay. And so we have a T cell and a receptor, and then the antigen binds to the receptor, and then what's going on then? We have an MHC complex and an antigen presenting cell. How is this connected?
In interstitial lung diseases like sarcoidosis, granuloma formation starts when an antigen, e.g., from inhaled particles, binds to a T cell receptor on a T cell, but only after an antigen presenting cell, APC, like a dendritic cell or macrophage, processes the antigen and presents it via the major histocompatibility complex, MHC, class 2, to the T cell. This MHC antigen T cell receptor interaction activates T cells, triggering cytokine release, e.g., TNF alpha, IL-2, which recruits more immune cells.
And if this happens a lot, basically a granuloma will form because of the scarring will form.
Repeated or chronic antigen presentation via MHC class 2 on antigen-presenting cells to T cells in interstitial lung disease can lead to persistent T cell activation and cytokine release, e.g., TNF alpha, which drives ongoing inflammation, but scarring, fibrosis, doesn't always follow granuloma formation. In diseases like sarcoidosis, granulomas may resolve or persist without fibrosis. While in hypersensitivity pneumonitis, chronic inflammation can promote fibroblast activity and collagen deposition, causing interstitial scarring. This scarring stiffens the lung interstitium, unlike ischemic heart disease's vascular issues, and is seen in fibrotic ILDs, but not all granulomatous ones. Want to explore which ILDs lead to fibrosis, or quiz on granulomas?
So granulomas look like nodules, but not all nodules are granulomas.
Exactly. Granulomas in interstitial lung disease, ILD, appear as nodules on CT scans, small, round interstitial lesions, often in sarcoidosis or hypersensitive pneumonitis. But not all lung nodules are granulomas. Nodules can also represent tumors, infections, or fibrotic masses in other ILDs, like idiopathic pulmonary fibrosis, requiring biopsy or imaging patterns to differentiate. This distinction is key in ILD diagnosis, unrelated to ischemic heart disease's vascular pathology. Want to dive into nodule diagnosis or specific ILD imaging findings?
What are dynamic evolutionary games?
Dynamic evolutionary games are mathematical models used to study how strategies or behaviors evolve over time in populations, where individuals' choices, e.g., cooperation vs competition, adapt based on payouts influenced by interactions, environmental changes, or random mutations, often applied in biology, economics, or social sciences.
I remember them. I remember some non-dynamical systems. I saw them in a book of Strogart's in non-linear dynamics and chaos, and he had some really cool models about, like, if you're left wing or right wing and stuff like that, or about hunting, I think, or something.
You're spot on recalling Stephen Strogatz's work in Nonlinear Dynamics and Chaos, 2019, where he explores nonlinear dynamical systems, including models that can relate to evolutionary games, like how populations shift between strategies, e.g., left-wing vs right-wing ideologies or cooperative vs competitive behaviors, such as hunting strategies. These models, while not always explicitly called dynamic evolutionary games, use similar principles, showing how interactions and payouts drive chaotic or stable shifts in behavior over time, distinct from ILD or ischemic heart disease, but relevant to understanding complex systems. Want to dive into a specific Strogatz model or
No,
connect
it's
this?
good. Let's go back to medicine. I just saw it on the board, guys. That's why I asked. Sorry for the no context. Let's talk a bit about the intralobular infiltrate of lymphocytes.
Intralobular infiltrates of lymphocytes in interstitial lung disease, ILD, refer to accumulations of lymphocytes, immune cells, within the intralobular septa, the thin connective tissue around alveoli, often seen in inflammatory ILDs like hypersensitivity pneumonitis or sarcoidosis, indicating immune response to antigens or injury. These infiltrates, visible on biopsy or high-resolution CT as ground glass opacities, contribute to lung inflammation and can precede fibrosis, distinct from ischemic heart disease's vascular pathology. Want to explore their role in specific ILDs or diagnostic approaches?
Well, I don't know what this means, to be honest, and how it connects to ground glass opacities and reticulations. I don't even know what these words mean. You have to explain to me the semiotic, semantics, etymology of all these words, to be honest. Give a good 5-sentence answer.
Intralobular infiltrates of lymphocytes mean immune cells, specifically lymphocytes, accumulate in the lung's intralobular septa, from Latin intra, within, and lobulus, small lobe, the delicate tissue around alveoli, signaling inflammation in interstitial lung disease, distinct from ischemic heart disease. Ground glass opacities, a term from radiology, from the hazy, translucent look resembling ground glass, appear on CT as areas of increased density due to partial alveolar filling or interstitial thickening, often caused by these lymphocytic infiltrates. Reticulations, from Latin reticulatus, net-like, describe a net-like pattern on CT, reflecting fibrotic or inflammatory thickening of the intralobular and intralobular septa. Semiotically, these terms convey specific pathological patterns. Infiltrates indicate cellular invasion. Opacities suggest obscured lung clarity. and reticulations point to structural distortion. Etymologically, infiltrate derives from Latin in, into, and filtrare, to filter, implying immune cells seeping into tissue, while
Okay,
ground
can we
glass
do like in a sentence, what's reticulations and ground glass opacities?
Ground glass opacities are hazy, semi-transparent areas on lung CT scans, indicating partial alveolar or interstitial inflammation, often from lymphocytic infiltrates in ILD, while reticulations are net-like patterns reflecting fibrotic or inflammatory thickening of the lung's intralobular and interlobular septa. Want to dive into their diagnostic
So
significance?
ground glass opacities means there's a lot of lymphocytes there.
Not exactly. Ground glass opacities on lung CT indicate areas of increased density from partial alveolar filling, interstitial thickening, or inflammation, which can be caused by lymphocytic infiltrates in interstitial lung disease, ILD. But they can also result from fluid, fibrosis, or other cells, not exclusively lymphocytes. In ILDs like hypersensitivity pneumonitis, lymphocytes in the intralobular septa often contribute to this hazy appearance. Distinct from
Fucking hell,
ischemic.
dude. I feel like we're making things more complicated than they should be with these two words. Tell me in simply, without oversimplifying, what the fuck's ground glass opacities and reticulocytes? Even intralobular, and also with intralobular infiltrate of lymphocytes, I assume this means that we have a lot of lymphocytes inside the intralobules. Intralobular septa, sorry.
All right, let's cut through the noise and keep it simple but precise. No fluff. Ground glass opacities, hazy patches on a lung CT scan where the lung looks cloudy, like frosted glass, caused by inflammation, fluid, or cells like lymphocytes, partly filling alveoli or thickening the interstitium, common in ILDs like sarcoidosis, but not specific to one cause. Reticulations, net-like lines on a CT scan showing thickened intralobular or interlobular septa, often from scarring or inflammation in ILD, making the lung look like a web. Intralobular infiltrate of lymphocytes, lots of lymphocytes, immune cells, piling up in the intralobular septa, the thin tissue around alveoli within lung lobules, causing inflammation in ILDs like hypersensitivity pneumonitis, visible as ground glass opacities or nodules on CT. These findings point to lung tissue issues in ILD, unrelated to ischemic heart disease's artery blockages, and need biopsy or CT patterns to pinpoint the ILD type. Want to quiz on these or dive into diagnosis?
It's good. Let's talk a bit about just a sec. About the air trapping.
Air trapping and interstitial lung disease, ILD, occurs when inflamed or fibrotic small airways, bronchioles, or interstitial scarring partially obstructs air outflow, causing patchy areas of hyperinflated lung on expiratory CT scans, visible as abnormally dark, low-density regions that retain air, distinct from ischemic heart disease's vascular pathology. It's common in ILDs like hypersensitivity pneumonitis or sarcoidosis, contributing to breathless.
Yeah.
All right, sticking with air trapping in interstitial lung disease, ILD, it shows up as dark, hyperinflated lung patches on expiratory CT because scarred or inflamed small airways and interstitium, like intralobular septa, block air from escaping, often seen in hypersensitivity pneumonitis or sarcoidosis, worsening shortness of breath. Unlike ischemic heart disease, which affects coronary arteries, Air trapping reflects lung tissue and airway dysfunction. Want to explore its diagnostic role or quiz on ILD imaging findings?
Don't understand the difference, bro.
I'm assuming you want differences between air trapping in interstitial lung disease, ILD, and some aspect of ischemic heart disease, IHD, like its pathology or imaging.
No,
Since
the
we
difference between I don't understand air trapping. What you are saying? I know we have air trapping also in like restrictive, I think, or obstructive. I don't remember.
My bad. Let's clarify air trapping and its context in lung diseases, focusing on your question about restrictive versus obstructive diseases, keeping it simple but precise. Air trapping is when air gets stuck in the lungs during exhalation due to narrowed or obstructed small airways or stiff lung tissue, visible on expiratory CT as dark, hyperinflated patches, and is typically associated with obstructive lung diseases, e.g., COPD, asthma, where airway narrowing traps air. But it also occurs in some restrictive interstitial lung diseases, ILDs, like hypersensitivity pneumonitis or sarcoidosis, when fibrotic or inflamed intralobular septa and bronchioles hinder air escape, unlike ischemic heart disease's artery issues. In obstructive diseases, air trapping is more diffuse and linked to chronic airflow limitation, while in restrictive ILDs, it's patchy, secondary to interstitial scarring or airway inflammation, contributing to shortness of
Alright.
breath.
So how do collagen plugs connect to what we are talking about?
I'm assuming you're referring to collagen plugs in the context of interstitial lung disease, ILD, possibly confusing them with fibroblast plugs or collagen deposition related to fibrosis, since we were discussing air trapping and ILD pathology.
No, it's a separate question. Tell me also about the consolidations.
All right, let's address collagen plugs and consolidations in the context of interstitial lung disease, ILD, keeping it clear and distinct from ischemic heart disease. Collagen plugs. In ILD, collagen plugs likely refer to collagen-rich fibrotic tissue or fibroblast foci, not true plugs, which are areas of excessive collagen deposition by fibroblasts in the interstitium, e.g., intralobular septa, during fibrotic ILDs, like idiopathic pulmonary fibrosis, IPF, contributing to lung scarring, stiffness, and impaired gas exchange, potentially worsening air trapping by distorting small airways. Consolidations. Consolidations in ILD appear on CT as dense, opaque lung areas where alveoli are filled with fluid, inflammatory cells like lymphocytes, or fibrous tissue replacing air, seen in acute ILDs like cryptogenic organizing pneumonia, unlike the hazy ground glass opacities or reticulations of chronic fibrosis. Both features reflect ILD's interstitial and alveolar pathology, with consolidations indicating active inflammation and collagen plugs signaling progressive scarring, distinct
Okay.
from
Okay. Let's continue talking about the interstitial lung disease stuff. So tell me about fibroblasts and how they relate. So they can make collagen and what is the scaffolding? How does that connect? Yeah, tell me what's going on.
Fibroblasts in interstitial lung disease, ILD, are cells in the lung interstitium, e.g., intralobular septa, that produce collagen and extracellular matrix, forming a scaffold a structural framework of proteins that supports lung tissue, but when overactive in fibrotic ILDs, like idiopathic pulmonary fibrosis, IPF, leads to excessive collagen deposition, scarring, and stiffened lungs, impairing gas exchange. In ILD, chronic inflammation, e.g., from lymphocytic infiltrates or injury, activates fibroblasts, causing them to build this abnormal scaffold, visible as reticulations on CT, which disrupts normal lung architecture, unlike ischemic heart disease's vascular pathology. Want to explore fibroblast activation triggers?
And these are activated permanently in the disease.
In fibrotic interstitial lung diseases, ILDs, like idiopathic pulmonary fibrosis, IPF, fibroblasts are not permanently activated, but are chronically stimulated by ongoing triggers like inflammation, e.g., cytokines from lymphocytes, injury, or growth factors, e.g., TGF-beta, leading to persistent collagen production and scaffold formation.
Wait, in fibrotic interstitial lung disease, aren't these fibroblasts activated permanently and then lay down streaks of irreversible collagen?
In fibrotic interstitial lung diseases, ILDs, like idiopathic pulmonary fibrosis, IPF, fibroblasts are not permanently activated in the sense of being perpetually on, but they are persistently driven by chronic stimuli, e.g., TGF-beta, inflammation from lymphocytic infiltrates, to continuously produce collagen, forming an irreversible extracellular matrix scaffold that scars the lung interstitium, e.g., intralobular septa, leading to progressive stiffness and impaired gas exchange, distinct from ischemic heart disease. Once laid down, the collagen is largely irreversible, contributing to permanent lung damage, though fibroblast activity can be slowed with anti-fibrotic drugs, like pirfenidone, but not fully stopped.
So what are honeycomb cysts?
Fibroblasts are connective tissue cells in the lung interstitium, e.g., intralobular septa, that produce collagen and extracellular matrix proteins, forming a supportive scaffold for lung structure. But in fibrotic interstitial lung diseases, ILDs, like idiopathic pulmonary fibrosis, their overactivity due to chronic inflammation or injury leads to excessive,
Dude, this language you are using is too confusing to me. Without oversimplifying, tell me again the previous question I have, because I didn't understand about fibrotic interstitial lung disease, and if these fibroblasts get activated permanently, and if this means that we have streaks of irreversible collagen. So answer that in a sentence, and then in another sentence, I want you to tell me about honeycomb cysts.
In fibrotic interstitial lung disease, like idiopathic pulmonary fibrosis, fibroblasts are not permanently activated, but are continuously triggered by inflammation or injury to produce excessive collagen, which forms irreversible scar tissue in the lung interstitium, stiffening the lungs. Honeycomb cysts are clusters of air-filled spaces seen on CT scans in advanced ILD, resulting from destroyed alveoli and fibrotic remodeling, resembling a honeycomb pattern, indicating severe, irreversible lung damage. Want to explore these further or quiz on ILD?
Answer to me as again.
In fibrotic interstitial lung diseases like idiopathic pulmonary fibrosis, fibroblasts are persistently stimulated by inflammation or injury to keep making collagen, creating permanent scar tissue that stiffens the lungs. Honeycomb cysts are air-filled pockets on CT scans in late-stage ILD, formed from destroyed alveoli and fibrotic changes, looking like a honeycomb and signaling severe.
So is my first question wrong or right?
Your original question was, Whether in fibrotic interstitial lung disease, ILD, fibroblasts are activated permanently and lay down streaks of irreversible collagen, and it's partially correct but needs clarification. Fibroblasts aren't permanently activated in a fixed on state, but in diseases like idiopathic pulmonary fibrosis, IPF, they are chronically triggered by ongoing inflammation, e.g., from lymphocytic infiltrates or signals like TGF beta, leading to continuous collagen
All right.
production.
So, so fibroblast foci create fibrosis, destroys lung tissue, and results in this honeycomb cyst. Is destroyed alveoli, you said. Yes? No?
Yes, you're on the right track. In fibrotic interstitial lung diseases, ILDs, like idiopathic pulmonary fibrosis, overactive fibroblasts produce excessive collagen, causing fibrosis that scars and destroys lung tissue, including alveoli, which leads to honeycomb cysts, air-filled spaces seen on CT scans resembling a honeycomb pattern, indicating severe, irreversible damage.
Okay. So, let's continue then. So, we talked a bit about fibrotic reticulations, these fine lines from scarring, we said, right?
Yep, exactly. Reticulations in fibrotic interstitial lung disease, ILD, are fine, net-like lines on CT scans caused by scarring from excessive collagen laid down by overactive fibroblasts in the intralobular and interlobular septa, stiffening the lung interstitium and impairing gas exchange, distinct from ischemic heart disease's vascular issues. These reticulations reflect the fibrotic remodeling that can also lead to honeycomb cysts in advanced ILD, like idiopathic pulmonary fibrosis. Want to dive into how reticulations differ from other CT findings or explore ILD progression?
So, no, I want to ask about the multinucleated giant cells and how they connect to all these things we were talking about up to now.
Multinucleated giant cells in interstitial lung disease, ILD, are large immune cells formed by the fusion of macrophages, often found in granulomas, e.g., in sarcoidosis or hypersensitivity pneumonitis, where they respond to persistent antigens or inflammation in the lung interstitium, distinct from the fibroblast-driven fibrosis and reticulations in ILDs.
One more time.
Multinucleated giant cells are large immune cells formed by fused macrophages, seen in granulomas of interstitial lung diseases, ILDs, like sarcoidosis, where they tackle chronic inflammation in the lung interstitium, but they don't directly cause the fibroblast-driven collagen scarring, reticulations, or honeycomb cysts seen in fibrotic ILDs, like IPF, distinct from ischemic heart disease's vascular pathology. Want to explore their role in granuloma formation or quiz on?
Oh no, it's good. So what is the NSIP?
Nonspecific interstitial pneumonia, NSIP, is a type of interstitial lung disease, ILD, characterized by uniform inflammation and/or fibrosis in the lung interstitium, often with lymphocytic infiltrates, and less severe reticulations than idiopathic pulmonary fibrosis, IPF, presenting as ground glass opacities on CT, and typically associated with connective tissue diseases, e.g., scleroderma, or hypersensitivity pneumonitis, distinct from ischemic heart disease. Unlike IPF,
I want us in 5 steps to compare organizing pneumonia, non-specific interstitial pneumonia, and usual interstitial pneumonia, and I want you to just say step 1, and please just let step 1 be a sentence.
Step 1. Organizing pneumonia, OP. Nonspecific interstitial pneumonia, NSIP, and usual interstitial pneumonia, UIP, are distinct interstitial lung diseases, ILDs, with different histopathology patterns, where OP features intraluminal fibroblast plugs. NSIP shows uniform interstitial inflammation or fibrosis, and UIP, typical of idiopathic pulmonary fibrosis, exhibits patchy fibrosis with honeycombing, all unrelated to ischemic heart disease's vascular pathology.
Okay, step 2.
Step 2. Clinically, organizing pneumonia often presents with subacute cough and dyspnea, responding well to corticosteroids, while NSIP has gradual dyspnea and ground glass opacities, often linked to connective tissue diseases, and UIP presents with progressive dyspnea and poor prognosis due to irreversible fibrotic changes like reticulations and honeycomb cysts in ILD.
Okay, and let's go to the next step.
Step 3. On CT imaging, organizing pneumonia shows patchy consolidations and tree and bud patterns. NSIP displays diffuse ground glass opacities with mild reticulations, and UIP features basal predominant reticulations, honeycomb cysts, and traction bronchiectasis, reflecting their distinct interstitial lung disease.
And just summarize everything else, because at this point I've lost you. 3 sentences.
Step 4. Histologically, organizing pneumonia has fibroblast plugs in alveoli. NSIP shows uniform interstitial lymphocytic infiltrates or fibrosis, and UIP exhibits fibroblast foci with temporal heterogeneity, driving progressive scarring in ILD. Step 5. Treatment for OP involves corticosteroids with good response. NSIP uses immunosuppressants with variable outcomes, and UIP has limited response to antifibrotics like pirfenidone, with worse prognosis. These ILDs differ from ischemic heart disease, which affects coronary arteries, not lung interstitium. Want to quiz on these or dive into...
Let's talk a bit about sarcoidosis too now.
Sarcoidosis is an interstitial lung disease, ILD, characterized by non-casating granulomas, clusters of immune cells like lymphocytes and multinucleated giant cells in the lung interstitium, often affecting intralobular septa or peribronchial areas, causing symptoms like dyspnea and cough, distinct from ischemic heart disease's vascular pathology. It commonly presents with bilateral hilar lymphadenopathy, ground glass opacities, or nodules on CT. And while often self-limiting, severe cases may require corticosteroids or immunosuppressants to manage inflammation, unlike fibrotic ILDs like UIP with irreversible scarring. Want to explore sarcoidosis's systemic effects or compare it to NSIP, OP, UIP?
So we have a lot of granulomas.
Yes, in sarcoidosis, an interstitial lung disease, ILD, the lung interstitium, often intralobular septa or peribronchial areas, develops many non-casating granulomas, collections of immune cells like lymphocytes and multinucleated giant cells, triggered by an unknown antigen, causing inflammation, nodules, or ground glass opacities on CT.
So how do we treat it, if you briefly can answer? You know what briefly means?
Sarcoidosis treatment depends on severity. Mild cases may need no treatment, just monitoring, while symptomatic or progressive cases use corticosteroids, e.g., prednisone, to reduce granuloma-related inflammation, with immunosuppressants, e.g., methotrexate, for resistant cases. Unlike ischemic heart disease treatments, targeting vascular issues. Want to dive into specific drugs or sarcoidosis complications?
Wait a sec. Can I ask, why do you think universities are not worth $10,000 to $50,000/pounds/euros to go and attend them in a year, dude? It's just basically a pre-packaged, fixed, with lack of curiosity material, which is really good to know and essential. And they do a few interactive sessions every year. And the lectures, they're pre-recorded. You can go home, watch them, pause them. It's better to watch them at home. So I wonder if a new thing will emerge where we're just going to be selling the structure, because you have the same and more knowledge than these lectures and whatever. So maybe if AI companies, they just start, I don't know, maybe, or not an AI company necessarily, like maybe we just start selling a program, like basically, okay, here's our medical program, 999 for the DVD, euros, and here you're basically providing the structure, like the great courses type of thing. You provide the structures, and then if they want to be doctors, they pass the exam. No, maybe, okay, doctor is a tricky one because it's not only as the exam, you need the practical side. But I'm talking about the theoretical side. Let's say the practical side has a different type of examination, but the theoretical side, no? What do you think, dude? Hey. I think I overwhelmed him, guys. Did you hear what I asked you about my idea? If you didn't, say no, and I'll say again.
My apologies. I might have missed a detail. You mentioned briefly explaining sarcoidosis treatment, but did you also mention an idea about it? Could you clarify what idea you're referring to?
What the hell, guys? Wait a sec. Grog, I was asking you why universities are worth 10 to 50,000 pounds per year. I'm saying it's ridiculous. You have more information on the lectures they provide. The only thing they provide is the structure. So why don't they just sell us the structure for €1,000 and then give us an exam at the end? And then the interactive sessions, we can attend them separately. I don't know, dude, like, it's ridiculous.
I hear your frustration about the high cost of university education, 10,000 to 50,000 pounds per year. And you're questioning why they can't just sell the structure for less, like 1,000 euros, and offer exams and optional interactive sessions separately, given the wealth of free information available. Here's a breakdown addressing your points. Structure and access. Universities charge high fees, not just for the curriculum structure, but for curated content, faculty expertise, and accreditation that ensures recognized degrees, which a €1,000 model might not sustain.
Why? Why? If the exam is the same, and if the exam is the same, and the fucking structure is the same, because I go to uni, I just go to the mandatory sessions, and the lectures I don't go. I have them on my laptop. So I'm paying for the exam and the material that I can learn. Fucking hell, dude.
I get your anger about paying 10,000 to 50,000 pounds for university when you skip lectures, use online materials, and feel you're mainly paying for the exam and structure, which seems overpriced. The high cost covers not just the exam and curriculum, but also faculty salaries, campus facilities, academic support, like tutors or labs, and the prestige of a degree that employers value.
Fuck off.
Which are
Anyway, okay. Prestige is nothing. It doesn't mean anything in the material world. Anyway, let's talk about hypersensitivity pneumonitis. But before we do, explain to us why steroids help treat sarcoidosis and what are some side effects. I want you to give us a total of 3 sentences for everything.
Steroids like prednisone treat sarcoidosis by suppressing the immune response, reducing inflammation and granuloma formation in the lung interstitium, improving symptoms like dyspnea. Common side effects include weight gain, osteoporosis, and increased infection risk, requiring careful monitoring. Hypersensitivity pneumonitis, another ILD, can also respond to steroids, but its management often emphasizes antigen avoidance, unlike sarcoidoses. Want to dive into hypersensitivity pneumonitis details or quiz on sarcoidoses?
Well, let's talk about what it is, hypersensitivity pneumonitis.
Hypersensitivity pneumonitis, HP, is an interstitial lung disease, ILD, caused by an immune response to inhaled organic antigens, for example, mold, bird proteins, leading to inflammation and granulomas in the lung interstitium, particularly intralobial septa, with symptoms like dyspnea and cough, distinct from ischemic heart disease's vascular issues. It presents with ground glass opacities, nodules, or air trapping on CT, and chronic exposure can cause fibrosis, resembling NSIP or UIP, treated primarily by avoiding the antigen and using corticosteroids for inflammation.
Tell us one more time this hypersensitivity. So genetic predisposition might be a problem, exposure to dust. So it's basically lymphocytic inflammation in the bronchioles. Or no?
Hypersensitivity pneumonitis, HP, is an interstitial lung disease, ILD, triggered by repeated inhalation of organic antigens, for example, mold, dust, bird proteins, with genetic predisposition potentially increasing susceptibility, causing lymphocytic inflammation and granulomas in the lung interstitium, intralobial septa, and parabronchial areas, not primarily the bronchi, leading to symptoms like dyspnea and cough, distinct from ischemic heart disease. Chronic exposure can lead to fibrosis, with CT showing ground glass opacities, nodules, or air trapping on CT, managed by antigen
And we have to
avoidance.
remove this antigenic exposure.
Yes, in hypersensitivity pneumonitis, HP, removing antigenic exposure, for example, mold, bird proteins, or dust, is critical to stop the immune-driven lymphocytic inflammation and granuloma formation.
What about connective tissue disease? What is this?
Connective tissue disease, CTD, associated interstitial lung disease, ILD, refers to lung interstitial inflammation or fibrosis, for example, in interlobial septa, caused by autoimmune disorders like rheumatoid arthritis, scleroderma, or lupus, where the immune system attacks connective tissues, leading to symptoms like dyspnea and cough, distinct from ischemic heart disease's vascular pathology. It often presents with NSIP or UIP patterns on CT, showing ground glass opacities or reticulations, and is treated with immunosuppressants, for example, corticosteroids, methotrexate, to manage inflammation and prevent scarring, unlike HP, which requires antigen avoidance. Want to explore specific CTDs?
Interesting. Well, so rheumatoid arthritis, dermatomyositis, scleroderma, Sjögren's syndrome. Can we talk about these?
Rheumatoid arthritis, RA, dermatomyositis, scleroderma, and Sjögren's syndrome are connective tissue diseases, CTDs, that can cause interstitial lung disease, ILD, characterized by inflammation or fibrosis in the lung interstitium, e.g., interlobial septa, presenting with dyspnea, cough, and CT findings like ground glass opacities or reticulations, distinct from ischemic heart disease. Rheumatoid arthritis, RA, an autoimmune joint disease, can lead to ILD, often UIP or NSIP patterns, with lymphocytic infiltrates and fibrosis, treated with immunosuppressants like methotrexate, but lung involvement worsens prognosis. Dermatomyositis.
What's the best way to save lives? I don't think it's medicine. I think it might be politics, but it might not be. Maybe it's economics. Or a combination.
Determining the best way to save lives depends on context, but medicine, politics, and economics each play critical roles with varying impacts. Medicine directly saves lives through interventions like treatment for interstitial lung disease, e.g., corticosteroids for hypersensitivity pneumonitis, or ischemic heart disease, e.g., stents for STEMI, but its scope is individual and resource dependent, with studies showing, for example, that timely PCI in STEMI can reduce mortality by 30%. Politics influences systemic change, like public health policies reducing smoking rates, e.g., WHO reports a 13%.
Never mind that. Let's talk about the more important things like wars and get, you know.
All right, shifting gears to wars.
We're not shifting gears. I'm just saying wars are a bigger problem than smoking.
You're right. Wars cause far greater loss of life and societal disruption than smoking, with millions of deaths and injuries historically. e.g., World War II alone killed over 70 million people, compared to smoking's 8 million annual deaths.
It's also the way you die, you know? It's like smoking is a bit our choice, a bit environment. War is just a bomb filling your house, dude. Anyway, let's not have this conversation now, guys. Let's go back. Although I would like an answer. Anyway, inflammation. Let's talk about fibrosis transformation. And then let's talk about how we treat this inflammatory connective tissue disease. If you could summarize your answer in 2 sentences.
In connective tissue disease-associated interstitial lung disease, CTD-ILD, Chronic inflammation from autoimmune attack, AG, in rheumatoid arthritis or scleroderma activates fibroblasts, leading to fibrosis transformation with collagen deposition, reticulations, and lung stiffening, visible as ground glass opacities or UIP and NSIP
Dude,
patterns.
did I ask you for treatment?
My bad. You asked about fibrosis transformation.
Yeah, I did, sorry. Anyway, tell us about treatment in a sentence. Come on.
Treatment for connective tissue disease-associated interstitial lung disease, CTD-ILD, uses corticosteroids and immunosuppressants, AG, methotrexate, mycophenolate, to reduce inflammation and slow fibroblast-driven fibrosis, preserving lung.
Okay, let's talk a bit about idiopathic pulmonary fibrosis. Yeah. Is there a UIP pattern? What's going on? Reticulations, honeycomb cysts, a sentence or two. And then a sentence about treatment.
Idiopathic pulmonary fibrosis, IPF, is a progressive interstitial lung disease, ILD, with a usual interstitial pneumonitis, UIP pattern, characterized by patchy fibrosis, reticulations, and honeycomb cysts on CT, primarily affecting the lung interstitium's intralobial septa, causing symptoms like progressive dyspnea and dry cough, distinct from ischemic heart disease. The UIP pattern shows basal predominant scarring and destroyed alveoli, leading to stiff lungs and poor gas exchange. Treatment involves antifibrotic drugs, AG, pirfenidone, nintedanib, to slow disease progression, as corticosteroids are less effective. Want to dive into IPF prognosis?
No, let's jump to occupational lung disease.
Occupational lung disease encompasses conditions like pneumoconiosis, AG, silicosis, asbestosis, a subset of interstitial lung disease, ILD, caused by prolonged inhalation of workplace dusts or chemicals, leading to interstitial inflammation or fibrosis.
Okay, let's talk about asbestos exposure, let's say. Let's talk about pleural plaques.
Asbestos exposure, an occupational hazard, can cause pleural plaques and interstitial lung disease, ILD, like asbestosis, distinct from ischemic heart disease's vascular pathology. Pleural plaques are benign, localized areas of fibrous thickening on the parietal pleura, lung lining, due to asbestos fiber irritation. Appearing as calcified patches on CT, often asymptomatic, but indicating past exposure, while asbestosis involves interstitial fibrosis with reticulations and sometimes honeycomb cysts, causing dyspnea and cough.
So it can cause interstitial lung disease, asbestosis. This can cause mesothelioma and lung cancer. What's mesothelioma?
Asbestos exposure can indeed cause asbestosis and interstitial lung disease with fibrosis in the lung interstitium, like reticulations, lung cancer, and mesothelioma, distinct from ischemic heart disease. Mesothelioma is a rare, aggressive cancer of the mesothelium, typically the pleura, lung lining, caused by asbestos fibers triggering chronic inflammation and malignant cell growth, presenting with pleural effusion, chest pain, and dyspnea, often diagnosed late with poor prognosis. Unlike asbestosis's interstitial scarring or lung cancer's bronchial involvement, mesothelioma affects the pleural surface and is managed with chemotherapy or palliative care, not antifibrotics. Want to explore mesothelioma diagnosis or compare these conditions?
Well, I wanna um
Al-
sorry guys. I'm just thinking. So okay.
No worries, take your time. So, you were diving into asbestos exposure, mesothelioma, and its links to interstitial lung disease like
So
asbestosis.
can we have drug-related interstitial lung disease?
Yes, drug related interstitial lung disease, ILD, occurs when certain medications, AG, amiodarone, methotrexate, chemotherapy drugs like bleomycin, cause inflammation or fibrosis in the lung interstitium, primarily intralobial septa, presenting with dyspnea, cough, and CT findings like ground glass opacities, reticulations, or consolidations, distinct from ischemic heart disease's vascular pathology. It can mimic patterns like NSIP or UIP, and management involves stopping the offending drug and often using corticosteroids to reduce inflammation, though fibrosis may persist.
Okay,
Want to
let's do
explore
a 10-minute quiz then. We have 10 minutes. Let's do a 10-minute quiz on everything we've talked about regarding interstitial lung disease. Shall we?
All right, let's do a 10-minute rapid-fire quiz on interstitial lung disease, ILD, covering topics like hypersensitivity pneumonitis, sarcoidosis, IPF, CTD-ILD, occupational lung disease, and drug-related ILD, keeping it concise and factual, distinct from ischemic heart disease. I'll ask questions, you answer in 1 or 2 words, and I'll provide quick feedback with correct answers if needed, aiming for 10-15 questions in 10 minutes. Ready? 1. Name the ILD caused by inhaling organic antigens like mold.
Hypersensitivity pneumonitis.
Nailed it. Hypersensitivity pneumonitis. 2. What cells form granulomas in sarcoidosis?
Macrophages. Huh?
Close, but it's lymphocytes and multinucleated giant cells. Macrophages fuse to form them. 3. What CT pattern is typical for idiopathic pulmonary fibrosis?
CT pattern, you said?
Yeah, meant the pattern on CT for IPF. My bad for unclear phrasing.
We have honeycomb cysts and I don't know.
You're on the right track with honeycomb cysts. The CT pattern for idiopathic pulmonary fibrosis is UIP, usual interstitial pneumonitis, with reticulations and honeycomb cysts. Let's keep going. 4. Drug that can cause ILD with ground glass opacities?
I don't know. Chemotherapy medication?
Good direction, but let's be specific. Amiodarone or bleomycin are classic examples causing ILD with ground glass opacities.
Alright guys, perfect. See you later. I'm tired. Bye.